In this episode of the ASC Podcast with John Goehle, we check in on the latest news in the ASC industry, review some recent experiences with facilities facing deemed status surveys, review credentialing basics, discuss accreditation and deemed status surveys and the benefits of accreditation, and interview the executive director of one of the newer national accreditation organizations, IMQ.
Welcome to the ASC Podcast with John Goehle, a bi-weekly podcast for anyone interested in the freestanding ambulatory surgery industry. This episode is sponsored by Ambulatory Healthcare Strategies. The ASC regulatory environment is increasingly challenging, but organizations that outsource their regulatory oversight to ambulatory healthcare strategies have an edge. AHS works with ASCs to oversee their quality improvement, risk management, emergency and infection control programs, run their meetings, develop education programs, and always be prepared for surveys. Welcome to episode 43 of the ASC Podcast with John Goehle for Monday, December 10th, 2018. We're recording from our studios in Rochester, New York. This is Sue Cronkite, Senior Nurse Consultant with AHS. I'm here with John Goehle. John is one of the leading experts in all aspects of the freestanding ambulatory surgery industry and the author of over 10 books about the ASC industry. John is a nationally known speaker and the owner of Ambulatory Healthcare Strategies. So it's been a little while. We've missed, I think we're running about a week past, but, we've been very busy and we're kind of rethinking things.
Absolutely. So we've been very busy with a number of centers under development. The funny thing, Sue, is we don't advertise Ambulatory Healthcare Strategies as a development company, and yet we currently have 4 projects that are under construction. So maybe we should advertise, or maybe Maybe we don't need to. But our name must be getting out there, and we're having a ball with it. Jenna Alvarez, who has been on the show in the past, and my daughter, and also one of our senior nurse consultants like you, she actually admitted the other day that she loves doing development work. Yeah. So unfortunately, that means that she will get all the development projects. Yep, so I don't know if she realized what
well, she's very good at it, though. She's really come to be an expert on that.
She's having a ball. So, it has been a while. I think, first of all, we need to celebrate something. This morning, we're recording on Saturday, December 8th, and this morning, you and I looked online, and we finally hit our 5,000 downloads. So Congratulations to us, and thank you to all of our listeners out there. 5,000 downloads, that's a heck of a number to achieve, and we're very proud of that. So. But with that comes changes, and we have been moving around our format a little bit over the last, now it's, oh my goodness, 11 months since we started, and we're finding our feet, I think, and we're trying to figure out ways that are that we can best achieve our goals, as well as get information into our listeners' hands. So one of the things that we moved away from was the weekly podcast in July, and went to a bi-weekly format. Now we're going to a more irregular schedule. And the reason for that is we just find that the industry does not fit into a nice weekly or bi-weekly format. For example, during the season of conferences, we'll probably be doing doing sessions weekly, or certainly when major news comes out, or when the newest regulations are issued. And then other times, it tends to be a little bit quiet. So it's been quiet for the last couple of weeks. We decided that we're going to move to this little less frequent format during the holidays. And I'll tell you, one of the reasons I did that, Sue, is because in talking to some of our listeners, and it's important to point out that we really live the quality assurance concept, quality improvement here. And we listen to our listeners. We talk to them all the time. And what we found is that most of our listeners are actually quite behind in the latest episodes. So, many, I go out on site and I say, how you doing? Did you listen to the most recent episode? Oh no, I'm probably about 4 or 5 episodes behind. Yep. So we realize that, you just don't have the time to listen to us weekly or sometimes not even bi-weekly. So, if you're not listening to us necessarily on that regular schedule, we're feeling that, we'll adjust our schedules accordingly. So,
a lot of the things that we talk about, I think, are applicable all the time. So even, if somebody started listening and then they find we aren't recording for a week or two, go back and listen to some of the old ones. I mean, I think that's just the way this format is.
Right.
That it can be pretty flexible.
But it's still, we do take very seriously our role in keeping up to date on the news. So that's one thing we will not move away from. And we're also trying to make a little bit more diversity in the content in each episode. We're going to try to make sure that all of our episodes at least have something for everybody that gets that's involved in the industry. So.
So, John, we've been on the road quite a bit with surveys that have happened with some of our clients, and we just wanted to talk about some things that come up and that we've learned.
Yeah, so we've been preparing for a survey for one of our facilities in New York City for quite a while. There was quite a number of things that we had to do with them to get them prepared, and then during the survey, a couple things that came up that we really haven't seen that much in the past. So we're going to talk a little bit about that. First of all, it was a very successful survey. There really were no major deficiencies at all, life safety issues, but of course we're always having that.
And I think sometimes when there's such a good survey, you can almost learn more from it because they're not picking up the obvious things, because those were pretty well covered. Everything they had taken care of any big issues.
Right.
And, they're able to really delve into some deeper things and give some good advice.
So some of the things that we did find out, one of the most recent survey, the surveyors were asking to see the annual appointment of committee members and by name. And that's not something that we have always traditionally done. Usually we kind of put a list into the committee books as to who is on the committee, but we don't always show annually an appointment. So we're going to be adding that to our regular cycle of appointments in our quality improvement and our governing body minutes.
I think you've talked about something like this before, just trying to keep kind of a regular schedule of things so you can always look back and find when people were credentialed, when any of these things had happened, in case somebody asks about that. Yeah,
try to have your quarterly meetings have a real good format, solid format to them, and keep track of all the annual things that you have to do. What I like to do in the minutes is I like to show, even if we didn't talk about an annual issue, we'll just say, the next time that the annual issue will come up is going to be in December, so that you can look at any set of minutes and know when these regular things pop around.
You don't miss it.
The second thing that came up was a life safety issue that I think is important to point out is that eye wash stations, they really do need to have water blending mechanisms. In other words, mechanisms that make sure that the water comes in at a temperature that is not going to hurt somebody when they put it into their eyes. A lot of the eye wash stations that are out there are either tied to the cold water or they rely on the person turning the faucet on to the correct temperature, and that is not safe for the individuals that are going to be using these eye wash stations. So that is something that you're going to see being cited. It's being cited by the life safety surveyors, and so make sure that you're replacing those old-fashioned eye wash stations with the proper ones that include some type of a mixing valve. I should also point out, I'm still seeing on the wall these green stations with a bottle of water for eye injuries, and those are just not appropriate at all. I don't even know why you would buy that. The amount of fluid that comes on that
not enough to flush.
It's not enough to flush the eye. So those are not appropriate and shouldn't be considered for any OSHA requirements here. Also, what came up in this last survey is annual documentation of fire training. The fire training was done, but we weren't seeing very solid training from the fire department on the use of the fire extinguishers. And this particular organization does annual training, but they weren't terribly diligent about making sure that was documented in a easy to find format.
And by that, you just mean they have to invite the fire department in to do that training.
Right. I really do recommend. I mean, it's not a requirement that the fire department do it, but that's a good way to do it if your fire department is interested in helping you out. Some places hire professional consultants that do these annual fire training, usually life safety people.
Yeah. The surveyor had actually said that was one of the most fun this one center had, is when they had the people come in and they got to experiment with the fire extinguishers and use them, and everybody's surprised by the kickback that you can get, and also just how quickly you run out of the extinguisher.
That's correct. And I think that it's really important for people to understand how their fire safety equipment works in the organization. So the takeaway from this is making sure that you have good annual documentation of that training that's in writing. I should also point a couple of things out as we were preparing this organization for survey and in general, as we're bringing on a lot more new centers, we're finding some trends here. So I just did want to talk about a couple of things that we've seen over the last probably about 6 months as we're preparing centers for surveys. And we'll continue to talk about this throughout, the months to come, but let's just delve into a couple. One of the things that I've seen is not a lot of good documentation of reviewing of the instruction manual for waiver tests. And in particular, I've noticed it with the pregnancy tests. Some people have even told me, pregnancy tests don't need to have any quality control testing. That's not true at all. So there's different types of pregnancy test kits out there. Some have a built-in quality control. Those are usually what's referred to as a cassette-based urine pregnancy kit, where you drop 2 drops, I believe, of urine into the cassette. One is for quality control and the other one is for the actual test. Those that don't have built-in quality control will require some type of testing, and usually that testing has to be done monthly upon new persons coming on board and learning how to use these tests, and anytime you open up a new package or a new batch. So it's important that you read the instruction manuals for these things to make sure you know what's doing. And it's funny because I've gotten into arguments, no, there's nothing here. And then I just say, can you pull out the instruction manual? And it doesn't take me long to point it out to them.
You read the directions?
I know, shocking as that might sound, Sue, I might not follow the directions around the house, but I certainly encourage our listeners to do it.
But seriously, that's something we always say, with anything, with cleaning, with, any type of machine or testing, or go with the manufacturer's instructions, at least to start with, make sure you have a good understanding of that. You can't just assume, because you've used a similar test. Right.
And not to make excuses for my not following directions and around the house, but, most of the things that we buy every day, we kind of know, and there's not serious ramifications of not reading those directions. But when it comes to those things that we use in our surgery centers, there's much more of a reason for doing that. Yeah. Another thing is, I'm going to make a comment about credentialing in general. A lot of our centers have been having some problems with credentialing, and it continues to be a big issue. It seems to be one of the top issues that come up when we are taking on a new center, is that their credentialing often is quite behind, or there's serious problems with it, or primary source has not been done. So we've done a number of episodes in the past about credentialing. I don't want to go into a lot of detail about that now, and perhaps we will have another episode coming up on it. But Sue, you read recently some information about that talks about the differences between credentialing, privileging, and peer review. And while this comes up is that I sometimes read minutes which will say that, we're credentialing such and such a provider, and that's not the right way to write it, because you're actually granting privileges, not credentialing, or granting credentialing. So why don't you talk a little bit about what you read?
There's very clear differences between them. And I was looking at the 2018 AAHC Quality Roadmap, and they just had a short paragraph that explained the difference.
And again, we're talking about the differences between credentialing, privileging, and peer review.
Yep. They're 3 separate but related processes. Credentialing means validating a provider's qualifications to offer healthcare services. Privileging is the process of governing body approval for a provider to deliver specific treatments, procedures, or to use specific equipment. And peer review is confirming a provider's competence by enlisting others of similar license, which is important, that there are people that do the same type of care, to review clinical records and other aspects of care, such as infection rates, patient wait times, compliance with medical staff rules and regulations, patient safety surveys. So, there's very clear ways to delineate those.
Right. And to that end, the delineation of privilege is an extremely important document that is often very poorly written, I would say, in many centers, or don't have all the privileges listed that are required for each of the providers. So just take a look at your credentialing and make sure it's up to speed. Follow the accreditation handbooks for your accreditation organization, and certainly check in on the conditions for coverage. Make sure you're following all of that.
Yep. And if they do change their different procedures or things that they're going to be doing, it has to be a very formal process. They can't just say, I'm going to start doing this other thing now.
I also found something interesting this last week. One of our centers is going through getting signed up for a new third-party payer. And that payer has asked for some very extensive details of how their credentialing works, and that so they've made some demands for much more specificity with regard to the policies and procedures. And as many of us know, the policies and procedures or the processes that we have in place for credentialing can be split sometimes between the medical staff bylaws and the policies and procedures of the organization. So it might be a good idea to kind of look at those two documents, make sure they're up to speed and that they have quite a bit of specificity as to how you go through the credentialing process. So be very careful with that.
Okay.
I do also want to point out something. We've seen a lot of issues with regard to credentialing companies, and I'm probably going to get into trouble because maybe some of our listeners are from credentialing companies, and now I'm going to get a whole series of complaints or comments that they have the best system out there. But our experience with credentialing companies is that sometimes they are often far more work than not going through that. And I can name it over and over again. So what we're finding is that these organizations that sign up for credentialing companies end up having to spend so much time following up to make sure that the credentialing companies are doing their time. They might as well just be doing the credentialing themselves. So be very cognizant of that. It might sound like a great idea. It might sound like you can, get rid of a credentialing coordinator in your organization by outsourcing to somebody else, but that is rarely the case. So be very careful on that matter.
Yeah. So there's a couple things I came across looking at some articles this week. So the FDA held a public meeting on November 27th on drug shortages and how they're working to identify the causes and solutions, because as we know, it's an ongoing problem. You can find information on their website of the FDA. And something that we've seen recently, I just wanted to remind everybody to be vigilant. Anytime you have to change your manufacturer of your drug, the drug concentration, it's so easy to make mistakes when you're used to a drug being packaged a certain way and you're used to it looking a certain way, and maybe something else comes in and it looks like maybe another drug that you have in your formulary. So always just be very careful about double checking and try to put some procedures in place, maybe a quick in-service saying, we have this new manufacturer and it's going to look this way, or putting stickers on any new medication until people get used to how it looks. And of course, reiterating, always double check, always look at it, read the medication name, concentration, just being very careful with that.
As well as the expiration date. I think sometimes we spend so much time looking for the expiration date that we forget to look for the drug name. And that should be verified. Obviously, that should be the first thing you're verifying there.
But I think that's the problem, is that when you get into the habit of doing things and you're used to, I pick up this bottle, it looks this way. And sometimes people just forget to look because they just assume everything's the same.
So be very careful with your drugs. Sue, we're carrying around you've made us all carry around in our briefcases drug labels now, so that we have a look like, sound alike, high alert drugs. And now we have a new label that you bought, which says what?
It says a medication is on back order, that it has expired, because sometimes, in your emergency kit, if the drug expires, we've seen people that just throw it all out, but then you have nothing in an emergency. So
epinephrine is probably the best example. You certainly don't want to remove it from your kit. Well, unless it expired a decade ago, but
I know. But otherwise, and I don't know, survey wise, but I think at least if you have this sticker, you can say, we're aware of it, we're trying, but we just aren't able to get a hold of it. So at least we thought we'd keep what we have.
I was taught when, as a surveyor, that we had to cite it anyway, but we would indicate so we would have to cite a situation in which the drug was on the cart, which was expired, even if it was on back order, but we wouldn't like turn it into a major event.
Yeah. And you'd certainly be cited more so if you just didn't have the medication.
Right.
So,
Absolutely.
That was a better idea. And just following up, we've talked a few weeks ago about the site neutral payments that have been proposed, and the American Hospital Association and America's Essential Hospitals, that's the AHA and the AEH, are expected to continue to challenge these new provisions, and they may end up taking the issue to court.
So this is a big topic, and I don't know where I stand on it. Certainly, one of the arguments that we have made in the ambulatory surgery industry all along is that, please come to us because we're cheaper than the hospital. But, and we understand why, hospitals are higher in payment. So I can understand the hospital side of this. But on the other hand, it does not seem right that they get paid considerably more for the same surgical procedure that we perform, where, there really isn't significant differences in the cost to provide those services, except for the overhead that are associated with these different organizations. We obviously in the ASC industry have significantly lower overhead costs than a hospital would have. So it'll be interesting to see how this plays out, and it could be a good thing for us in the industry as hospitals may realize that maybe it's, they shouldn't be doing these procedures there, and that they should be focused on the higher cost, higher revenue items that should be in the hospital environment.
Yeah. And an article in Modern Healthcare's December issue talked about the Trump administration's possible plan to use 1332 waivers to discourage states from having CON laws. And John, can you kind of explain what a 1332 waiver is?
Sure. Thank you very much. It's certainly not something I normally know a lot about.
More than me.
Preparing for this, I did do a little bit of research. So 1332 waivers are waivers under the Affordable Care Act that allow states to come up with innovative programs within that state to fund healthcare initiatives or to come up with unique healthcare programs or plans that would be used in that state. Interestingly, we both found out that there aren't a lot of waivers that have been approved, and actually very few have been approved. So I'm not sure how strong an incentive this particular item is for states to move away from CONs.
Yeah, it seems like more of a starting point, that it's just kind of showing the direction that things are probably going in.
Correct. From the administration standpoint. I think, and of course, I've been in the industry a very long time. I've been here, and all of my career, CONs have been in existence. We live in New York. New York has one of the strongest CON laws in the country. So, and I actually was involved in a local health systems agency back in the 90s. I served on one of the health systems agencies that helped to review certificate of need applications to determine if they should be approved by the state. But, CONs they're still in existence, but I think a lot of us kind of feel like they're extraordinarily outdated.
Yeah, and they haven't been federally mandated since 1986, but I think we'd said there was 36 states that have some form of a CON law. It might not all have to apply to
ambulatory surgery.
The ambulatory surgery, but
yeah. So that's I've always felt that these are very antiquated things, though our company does make quite a bit of revenue, I should say, on an annual basis by helping organizations get CONs approved. But it's one of those things I'd much rather not have to do, since it's a very cumbersome process, and it just seems like a waste of our time as well as the resources of our government to look at these.
And I think that's the thing. They want to encourage some competition,
right,
and just encourage the industry to grow. Now, something I did that was in this same article, the Modern Healthcare's December issue, again, they had mentioned that some states, I think they mentioned Nevada specifically, that might have different laws for the different areas, like in rural areas.
Right.
Because, although we want competition in some areas, if they're small rural hospitals, that if they were put out of business, could really be very detrimental to the population there. So it's an interesting. So
in other words, you're saying they're more protective in those areas.
In those areas where they don't want to lose.
Yeah.
Where if you had a lot of competition in it,
right,
and you lost that, there'd be nothing for the population to go to. So there's a lot of different angles on this.
So let's keep an eye on what's going on with the Trump administration's focus on this area, and see if it's going to be interesting to see over the next couple of years how CONs tend to evolve with competition coming into play. Let's take a break, and we'll come back and talk about accreditation and accreditation organizations.
So we thought we'd talk a little bit about accreditation. It's a voluntary process to review the processes in place in a healthcare organization to assure that they are meeting the standards established by the accrediting body. As part of the process, the accrediting body will conduct surveys to assess the organization's compliance with the standards, and organizations are expected to understand the standards and develop processes in the organization to ensure that they meet those standards.
So I actually wrote those bullet points for you, and the funny part is that third bullet. I cannot tell you, Sue, how many times I've walked into an organization, either as a surveyor or certainly as a consultant, and asked, one of the first questions I ask is, "Have you read the most recent accreditation manual?" And people will say no. And sometimes even ask the question, "Do you have the most recent accreditation manual?" And they'll say no. And what I don't understand is, why would you subject yourself to an accreditation survey if you actually didn't read the accreditation manual?
Yeah.
And I know one of the reasons that I hear a lot is because, we've had successful surveys in the past. We've never had any major problems. We always pass these surveys. So as long as I keep doing the same thing I was doing before, then I know I'm going to pass this time around. And that's really not a safe thing to do.
No.
And one of the things that I, as a surveyor, kind of point out is that every time that we come out, surveyors are going to have, different they come from different backgrounds, so they're going to often have different focuses when they come in. We have to review all of the standards, and we make sure that we review the standards as part of the survey, but some of the areas might receive more focus in one year than others will, simply because of the events that occurred in that organization within that year.
Yeah, or the particular survey, or everybody's got their particular areas they tend to look at more.
That's right. So it's extremely important, and one huge takeaway here is make sure that you get the most recent accreditation manual for your organization and follow up on it. And one thing to understand is standards can vary considerably by organization. So I thought we would just focus on the top 5 organizations out there, 2 of which people might not even actually know are out there. So, and that is one of the focuses of today. So we're actually going to have an interview later on. We did an interview in, I think it was Ohio, quite a number of months ago, with IMQ, which one of the newer organizations out there. And we had a wonderful discussion with one of the directors out there. And it's always interesting to see that this is an evolving industry, that indeed accreditation itself, just like our industries are not staying the same, accreditation is not staying the same. And there is competition coming out there. So this is hopefully putting some pressure on the accrediting organizations to continue to do a great job with their accreditation standards and to end the accreditation surveys and to meet the needs of the organization. But the standards, as I said, do vary considerably of the organization. The Joint Commission, for example, standards for the ambulatory surgery industry tend to be based on the hospital standards for operating room and outpatient centers. And, their standards have a very different flavor. I find that with the Joint Commission, you have a heavy reliance on the website. For example, you have to go up to the website on a regular basis, update information on the website. And I think they're really geared toward larger organizations that have resources or have individuals that can spend quite a bit of time focusing exclusively on Joint Commission standard compliance. AAHC, or the Accreditation Association for Ambulatory Healthcare, their standards tend to be more focused on the outpatient setting, and the stakeholders in the industry have actually helped to develop those standards and continue to develop them as time goes on. I am a AAHC accreditation surveyor, and obviously I have my personal love for that organization, and I support them wholeheartedly. But it's important that we understand that every organization has different standards. Now, another organization, the ASF, the American Association for Accreditation of Ambulatory Surgical Facilities, tend to be much more focused on outpatient surgery centers exclusively, and their surveys tend to be very physician focused, and the organization itself, ASF, is very physician focused. So all the major leadership in the organization are physicians, which varies quite a bit from the Joint Commission and AAHC. Now, there are a number of lesser-known accreditation organizations who have, different standards. And most of these smaller organizations, which are not available in all states, by the way, focus on ensuring the organization really meets the conditions for coverage. HFAP, which is the Health Facility Accreditation Program, which was, I think, acquired by AAHC a number of years ago and then spun off recently. HFAP's website states that the basis of the HFAP standards are the Medicare conditions of participation, which for each type of facility, which in the ambulatory surgery industry is the conditions for coverage. And the standards for each program are crosswalked to the conditions for coverage. This crosswalk approach means anyone reading the HFAP standards manual can clearly see how each standard ties directly to the Medicare requirements. HFAP standards are composed of all the Medicare standards plus standards proven to elevate quality and enhance patient safety. And compliance with HFAP requirements assures compliance with the Medicare standards. Approximately 80% of HFAP standards are crosswalked to the Medicare conditions of participation and conditions of coverage on the associated requirements. So one of our newer clients actually went through an HFAP survey recently and found it to be a wonderful experience. And the last organization we want to talk about is IMQ, which is the Institute for Medical Quality. And we're going to do an interview later on in this episode here. And it seems to be somewhat similar in approach to HFAP. It's a relatively smaller set of standards that, again, focus on the Medicare conditions for coverage. And their website points out that the IMQ accreditation standards for surgical and outpatient facilities manual features separate standards for solo and small groups and large medical group practices, and that meet or exceed the CMS Medicare requirements. And then a procedure for life safety code inspection is available for facilities seeking Medicare deemed status option. What I find interesting is I don't know of the other organizations actually having separate or different standards for small versus large groups. So I don't know quite how that works. And I don't think that's a question we actually asked in our interview. So maybe we'll get an answer to that at some point. Deemed status surveys versus an accreditation survey. So accreditation is in itself a voluntary process in most organizations. Now, there are some states that require you to be accredited. New York is one of them, for example. So if you're an ambulatory surgery center in the state of New York, within 2 years after starting operations, you have to be accredited also. But many organizations go for accreditation simply because they can also have their deemed status at the same time. And deemed status means that the organization decides to have an accreditation organization do their CMS survey for the conditions for coverage rather than their state. And the disadvantage here is that you have to pay for it, whereas you don't have to pay for a state survey. But the advantage is that you have one survey for accreditation and deemed status. And while it's going to be unannounced, unlike a regular accreditation survey, you're going to kind of know within a 6 to 9 month time frame when that survey is going to happen. I happen to like deemed status surveys, but the life safety part is often more challenging than some of the state surveys for life safety are. And there is a perception among some people that the state life safety survey is tougher than ones from a deemed status organization. Mm-hmm. That's just not true. This past week, we've been working with a center that has had some significant design issues that we're dealing with simply because the architects clearly did not know the federal requirements for construction and the life safety code. And they relied on the fact that the state approved the plans, even though there were clearly some items that were, very poorly done within the design. And I've been working with them in order to try to get those things fixed. So for many, many years, the major accrediting organizations such as AAHC and the Joint Commission have had pretty much a monopoly on accreditation in ambulatory surgery. So some of these smaller organizations such as HVAP and IMQ are coming online. And as I mentioned earlier, one of those organizations is IMQ, the Institute for Medical Quality. And we did have an opportunity during the Ohio State Association meeting to interview Victoria Samper, who is the Vice President for Ambulatory Programs. Sue, let's listen to this interview, and then we'll come back and talk a little bit about what she spoke about.
Okay. John and I are here at the Ohio Association of Ambulatory Surgery Centers annual conference in Columbus, Ohio, and we're going to talk to Victoria Samper. She is with IMQ, or the Institute for Medical Quality.
So, Victoria, you and I met at the California Association meeting, and we had an opportunity to talk, but we didn't have an opportunity to interview you at that point. And as a surveyor from another accrediting organization, I was just fascinated to hear about IMQ. I've heard about it. And I know you're really big on the West Coast, but a lot of our listeners from the East Coast.
Yes.
And you have an important story to tell. So, first of all, tell our listeners a little bit about IMQ.
Okay. Thank you very much. IMQ, the Institute for Medical Quality, is a physician-driven organization. We are a nonprofit public benefit corporation. We have a board of 17 physicians who are interested in quality. Our mission is to improve the quality of care provided to patients across the continuum across the United States. To do so, we have several accreditation programs. The one that we're talking about today would be the Ambulatory Surgery Center Outpatient Accreditation Program.
And you're based in California, correct?
We are based in California. We have been in California and operational for 22 years. About 7 years ago, we started moving into the national space. We have been recently approved as a deeming authority for Medicare for participation in the Medicare programs across the nation.
Sure. And which means that you can do surveys, a deemed status survey, anywhere in the country in all 50 states.
Absolutely. Yes.
Now, I understand you're not in all 50 states yet, though. And
Not
tell us
yet.
why.
Well, it takes time. It takes people to apply.
Right, right.
The transition from a previous accreditor to a new accreditor is always a hard transition. Mm-hmm. Mostly because you want to wait until it's time for your accreditation to expire. Nobody wants to take a test twice if they don't have to.
Right.
We do a lot of new facilities, and we're here if out there wants us.
Mm-hmm. So you told me a great story in California,
yes,
which really hit it because we do a number of startups ourselves. And periodically I run into this with accreditation surveys. That takes a while. You know, you start operations and you wait 5-6 weeks sometimes to get them in there. But so please tell me that story again.
Okay. Well, this was an ambulatory surgery center. It was a large ambulatory surgery center, 6 ORs. a surgery center that takes care of the San Francisco 49ers. Yay, 49ers. And they had been ready to go. They were just waiting for our competition to go in and do their deemed status survey. They had been waiting for 3 months for an accreditation survey. Now in California, the regulation is that you cannot start seeing patients until you're accredited. So they were just sitting there waiting. Yeah. And the woman called me and she said, "What do I do?" And I said, "You know what? This was a Friday afternoon." I said, "Do you have a copy of the application that you submitted to the other organization?" And she said, "I do." I said, "Photocopy it and drop it off at my office."
Yeah.
And I took that and I called one of my surveyors and I said, "I'm going to drop off a survey for you. You're going to prepare this weekend. And on Monday morning, you're going to go in and do a survey." And on Monday morning, we did the survey. On Monday afternoon, we had an extraordinary meeting of our committee that makes the accreditation decision. And by 6 p.m. Monday afternoon, we had an accreditation for them so that they could start seeing patients. Call to accreditation, 4 days.
Now, and this was a deemed status survey too.
That was not a deemed status survey at the time. However, in terms of accreditation, deemed status surveys, we are processing within 6 weeks of application receipt.
Okay. And how long does it take to get the report after the survey is done?
10 days by law.
For deemed status surveys.
Deemed status. CMS requires that we provide a report within 10 days.
Right.
If it is an accreditation survey and you are a new facility, again, we don't hold it. We process them immediately.
Okay.
So again, within 10 days of survey.
Okay. So which states are you in right now?
Right now, we work in 15 states because that's where people have been smart enough to go with IMQ, if I do say so myself.
Don't hold back.
The reality is we can do the nation.
Right.
There are some states that have legislation for office-based surgery, which we also do. I believe there are 25 of those states. We are in 9 of those states.
Okay.
Every other state is a voluntary issue, and so we can do accreditation surveys there, and we can, of course, do deemed status anywhere in the nation.
Right. And we talked a little bit about New York. We have quite a number of listeners from New York. So why don't you just tell us the situation in New York?
So we applied to New York, and what they found in talking to us, and this is not the only place that it's happened, is that we're very helpful to the bodies that have to put the legislation through. And in discussing how accreditation happened, they realized that perhaps their rules do not encompass everything that they should encompass. And so they are revisiting their rules, and then they will have all accrediting entities apply again. And at that time, they will revisit our application.
Wonderful.
So again, it was...
So just give it a little bit of time.
Give it a little time. I think the regs will be better.
Right.
Now, I'm curious about your history. Your organization is based in, or does a lot of education. Am I correct?
Our organization is based in California. It has been around for 22 years. We do accreditation for ambulatory surgery centers. We are the state provider of continuing medical education. And we also have an accreditation program for the healthcare provided in California jails.
Okay.
We've been doing accreditation surveys for 40 years. Before we were independent, we were the programmatic arm of the California Medical Association. And in that capacity, we provided the physician surveyors for both the Joint Commission surveys for hospitals in California and the physician surveyors for the AAAHC Ambulatory Surgery Center surveys in California.
Okay. And it sounds like that you're very consultative when you do a survey, that you really like to work with the people that are running the center.
Our philosophy is that the accreditation survey should not be a burden. You should not see it as a burden. On the contrary, we would like you to see us as a partner in being able to meet the regulations and provide the best quality care you can. And we developed a program that is pragmatic. Our standards, as you've seen, are 56 pages. They are written for the lay person. We understand that the person who usually is tasked to do the accreditation is not an expert in accreditation or in legal requirements or anything else. And so we try to help in that sense. We're also always available on phone, online for facilities that are working with us to ask questions. I don't understand this standard. Can you explain what I need to do? This is my policy. Is it going to meet the requirement? We're very happy to look at it all and answer the questions and help at every step of the way before, during, and after the survey.
So, Victoria, tell me a little bit about how your board of directors is structured.
The IMQ board of directors is 17 people, of which 15 are physicians. They are independent representatives. They represent themselves. They're all leaders in the field of quality in one way, shape, or form, and very much independent in the decisions that they make for IMQ.
And they're all multi-specialties, so they represent all the different...
Yes, all the different specialties, as well as the different ways of groups of providing healthcare. Some are with groups, some are independent, some are with educational facilities. So a very varied group of physicians.
And independent versus institutional or corporate.
They represent themselves. They are not representing any organization when they're on our board of directors.
Okay.
Yes.
So we've kind of answered this question, but what does make an IMQ survey different than the competitors?
Well, all our surveyors are volunteers. So they actually believe in what they do. We try very hard to match the specialty of the organization with the specialty of the surveyor.
That is different, yes.
Yeah.
Surveyors are instructed to follow our philosophy. We are educational and consultative. We're not there to get you. We're there to help you meet the requirements. I say we're also quite a bit less expensive. And our turnaround is very, very fast. As I said, 4 days in an emergency.
Yeah.
I don't like to operate like that all the time, but we can do it.
Yeah.
And, with new applicants, we're getting them through the system in 6 to 8 weeks.
Wow.
So if you have an ambulatory surgery center that's sitting there waiting,
Yeah.
we are the way to go.
This has been great, Victoria. Thank you so much for all the information you provided. And we'll put a link on our website to IMQ and the information that you can get there. And
Thank you very much. And again, invite your membership to call us. We can help.
Absolutely.
Okay.
Thank you.
Thanks.
Okay, so that was a great interview. I loved their focus on consultation and helping the organization. I think their small size really seems to be a benefit. And also that they match up the surveyor with the specialty.
Yeah, and I really love that story about how quickly they got a center through the initial survey and also how they used another organization's application. I think our point here is we really want people to look at all the organizations that are out there. I think competition is healthy for our industry, for the ASC industry, and it's healthy for the accreditation industry. Yeah. And organizations such as IMQ, which it's not a new organization, but it's kind of new to the ASC focus here. Hopefully we'll keep everybody on their toes. So I'd also found it interesting their focus on physicians, which is very similar to the Quad ASF focus in their organization. Certainly not the same thing as what you'll find in Joint Commission and AAHC, which and HVAP don't specifically focus only on physicians. So
I think the real takeaway here is that there's a lot of different options. You can think about the small companies as well as the big ones and just see what fits for your organization.
So I did want to point out that though while we only interviewed IMQ for this particular episode, we are looking into talking to some other organizations. Yep. We had a wonderful conversation with Joint Commission recently, and we want to talk to them because they're going through a lot of changes right now, and they have a new executive director for the ambulatory side. And I thought we'll try to bring her on the show sometime in the near future. Yeah. And if you're from another accreditation organization and like to be interviewed, give me a call or send me an email. All that information is available at the end of the show, and we'd be glad to talk to you.
Yeah.
So let's take a break, and we'll come back and talk about the upcoming events.
So, John, as our listeners know, Ambulatory Healthcare Strategies is the sponsor of the ASC Podcast with John Goehle, and we've experienced some pretty incredible growth in the past few years. Can you talk a little about what is going on?
Certainly. So a lot of our growth, of course, has been because of the podcast. I think people are getting to know us more, and I think they enjoy this biweekly format where they learn more about what's going on. It's been a very busy fall already. We picked up another 2 startups and 1 existing ASC. And by the way, we've never really been an organization known for working on startups, so that's quite a testament to our our growth right now. And we're now actually working with some management companies to help them manage their compliance programs. I think what they're finding is that sometimes it's better just to outsource that, compliance work to organizations such as ours that are really good at it. And it's less expensive for them to do that rather than manage it internally.
But the core of the business remains what you call retainer-based services, right?
That's correct. While we work with startups and centers that have gotten themselves into trouble with regulators, the core of our business is our retainer, which includes a range of services. And this range of services includes regular visits to the center, review of the quality improvement, risk management, infection control, and emergency preparedness plans, and the documentation surrounding them. Preparation for attendance at and preparation of the minutes for all the quality improvement, medical executive, and governing body meetings. Annual updates to the policy and procedure manuals to comply with state and CMS and accreditation requirements. Preparation of educational programs for orientation and annual mandatory education. And, of course, 24/7 access to me and my incredible staff for issues that might come up.
So how do our listeners learn more about this?
Well, give me a call, 585-594-1167, or send me an email at info@ah-strategies.com. So this is the second week in December when we recorded this episode, and the October test results are out for the CASC and the CAPE exam. That's the Certified Ambulatory Surgery Center Administrator and the Certified Ambulatory Infection Preventionist test. So if you took those tests electronically in October, you should have had your results by now. So congratulations to all the people that passed. We're so proud of you. I have a lot of inside information, which I can't say yet because it's not public, but the CAPE exam has been a big success, and we had quite a number of people take the test this cycle, and we are just so excited about how successful it's been. So definitely, if you are an infection preventionist, look into the CAPE credential at CAIP and go to the About CAPE .org website. And for those of you that are administrators out there, I assume you already know about the CASC exam and the importance of the CASC credential. You too go to the CASC, the aboutcasc.org website to get more information. So I do want to make a shout out to Lori Rodricks, who is the Ambulatory Healthcare Strategies Director of Clinical Services. She texted me on Friday that she passed.
Oh, good for her.
I had no doubt, she's very experienced, that I had no doubt that she would pass it, but, she was very nervous going into it, and we're very proud of her. And that's going to be a nice credential for all of our clients that require infection prevention services. Yep. So let's talk about some of the upcoming events in the ASC industry.
Every episode, we will inform you of upcoming events. If you would like your event to be included in the podcast, please send the event information to info@ascpodcast.com.
The 2019 ASCA Winter Seminars are January 17th through 19th in Austin, Texas at the Hilton Austin. The 2019 conference will include 3 tracks: ASC Management Essentials, Coding Update and Reimbursement Strategies, and Infection Prevention Techniques in ASCs. And Sue, I signed everybody up. Well, I signed a couple of us up. I should say everybody. Some people actually have to stay back and do some work, but you and I and Jenna Alvarez are going down there. You and Jenna are going to be focusing on the infection prevention track.
Yes.
I'll be speaking in the ASC Management Essentials track, and hope to see many of our listener friends out there. Make sure you stop by and say hi to us as we're out there. Hopefully we'll do an episode while we're out there too. Well, even if we don't have an official room to do the episode, we'll do it from the hotel room, whatever we have to do.
Come talk to us.
Come talk to us, right.
The next Certified Ambulatory Infection Preventionist, or CAPE exam, is scheduled for March 1st through 31st, 2019 at testing sites throughout the United States. Electronic application must be submitted January 1st to 31st, 2019. For more information, please visit aboutcape.org. That's aboutcaip.org.
The next Certified Ambulatory Surgery Center Administrator, or CASC exam, is scheduled for May 1st through the 31st, 2019 at testing sites throughout the United States. The electronic application must be submitted between March 1st and the 31st, 2019. And for more information, please visit aboutcasc.org, aboutcasc.org.
ASCA 2019 will be at the Gaylord Opryland Resort and Convention Center in Nashville, Tennessee, May 15th through the 18th, 2019.
And we're going to be there in force. Hope to see all of our listeners there. I have 3 sessions that I'm teaching while I'm there, and looking very much forward to going to one of my favorite places, the Gaylord Opryland and Nashville. We'll have a lot of fun there, Sue.
Yeah, it should be fun. And the Arizona Ambulatory Surgery Center Association, AASCA, annual conference is June 27th to the 28th, 2019 at the Camelback Inn and Spa in Scottsdale, Arizona.
Well, that's it for this episode of the ASC Podcast with John Goehle. Please spread the word about our podcast with your friends and colleagues and do us the honor of hitting the subscribe button.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all the rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development, all rights reserved. We would like to thank this week's sponsors. First, Ambulatory Healthcare Strategies, one of the nation's leading regulatory compliance and financial oversight firms. For a free consultation, contact John Goehle today at 585-594-1167 or through email at info@ah-strategies.com. And Eden Group Development, which publishes ASC Regulatory Compliance Series, the ASC Industry's leading books including the Survey Guide for ASCs, a guide to the CMS Conditions for Coverage and Interpretive Guidelines for Ambulatory Surgery Centers, and Ambulatory Surgery Center Governance, a guide for ambulatory surgery center owners and governing body members. These must-have books are available on Amazon and Barnes & Noble or directly from the publisher at reg-books.com. That's reg-books.com. If you are interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.